Top Med Talk.
Welcome to Top Med Talk. This piece is part 4 of a 4-part series. We're going to take you to the EBPOM World Congress, to a session called Implementation, What Works and What Doesn't. There have been 3 presentations that precede this question and answer session. They have featured David Probert, Chief Executive Officer at University College London Hospital's NHS Foundation Trust. He gave an NHS perspective on things. Tim Miller, Professor of Anaesthesiology at Duke University Medical Centre, and Joyce Yeung, Professor of Anaesthesia and Critical Care Medicine at the University of Warwick. Those presentations are now available for you to listen to here on Top Med Talk, and there are links to those presentations in the show notes. Also, in this question and answer session, Imogen Fecher-Jones is introduced to the stage. She's a lead nurse in perioperative services at University Hospital Southampton. The session is chaired by John Whittle. Unlike the previous podcasts, we're not sure this entirely works as a standalone piece, particularly if this is not an area of expertise for you. So we highly recommend you listen to the first 3 parts of this 4-part series. Links in the show notes. So let's have a listen to the conversation, Implementation, What Works and What Doesn't, Q&A session.
And I'd like to invite all our speakers up to the stage for our panel discussion. And we're also delighted to welcome Imogen Fecher-Jones, who's worked with us at Southampton for many years from an advanced nursing background, but has been pivotal in embedding our perioperative services program. So I'm just going to start, I think, perhaps popping back to ERAS for a little bit. There's a couple of the most popular question is talking about how, you've got something new and it's enhanced. Does it become standard even without pathways? Do we need to stop pushing it? But also there's another question slightly further down, implementation of enhanced recovery in the UK was very impressive, but have we had a decay curve since due to withdrawal of funding for facilitators? So I'm going to come to Imogen first, just to speak a little bit, because you were pretty much the person on the ground putting ERAS into place in Southampton, really, weren't you? What's been your experience over the years of implementing it? What's your take on whether it's decayed or whether it's just now the norm and we need to stop worrying about it?
I mean, I was very lucky in Southampton that I had a really amazing team behind me at the time, and we had Mike as well. He was our enhanced recovery lead. I remember going to this course in St Mark's, who were running the enhanced recovery course at the time. And I was only a band 6 nurse. This was literally 13 years ago. And coming back and saying, I think we should do this. And the colorectal surgeons were like, well, go on then. And I was like, oh, okay. But I guess I was lucky I had a young consultant team. Most of them were fairly new consultants coming in. We had some laggards, of course we did, and a fairly strong stakeholder group. So we started in colorectal, it then went to HPB, and we got some funding locally for that. And then we looked at a more sort of trust-wide project, and I took it on looking at some of the other specialities as well. But, that was a long time ago, and I'm looking back now and I can see that actually probably, less than 50% of those specialities are still running the enhanced recovery programs in the way that I would recognise them. So I'm afraid to say there is definitely been a decay. I think there's elements that are standard care for sure, but because there's so many elements, so many have dropped by the wayside. And I think the digitalisation of the nursing documentation hasn't helped us at all. We've lost our care pathways because people say, well, we know what we're doing now. We don't need this document day by day telling us what to do. But actually with the turnover of our nursing staff, that is a problem. They don't actually know each of the elements each day, the targets for the patients. I think for looking back, and for me, yes, I think we should be pushing more. Our length of stays have definitely drifted. And I do think that our surgeons should be asked those questions regularly, because actually the middle management, our care group management, again, high turnover. A lot of them don't even know about enhanced recovery. But I think the secret now, so many years on, is about patient education. And that's really where my love is now. And I'll be talking a bit more about that later. I remember early on doing some qualitative work, and a lot of our patients didn't even realise they were on an enhanced recovery programme. And I think even now patients probably still don't. The term doesn't mean very much to them. There's a lot we can learn in the last 13 years. Patient education, definitely. But really, we should be still challenging, still pushing. It's not standard care. I hope that answers your question.
Yeah, no, clearly. Thanks, Imogen. So coming to you, Tim, what's the kind of American perspective on that? Are there bits that just seem to have naturally embedded and you don't need to measure anymore? Or is it the case that as soon as you stop measuring stuff, it stops happening?
I think a bit of both. I think you need to look at your outcomes and decide where you want to focus. I think, for instance, at Duke, colorectal surgery, I mean, majority of it's done laparoscopically, robotically now. Patients are all fed and mobilized initially, and our average length of stay is 2 to 3 days. So even though it's not, and we haven't got a focus on re-engaging enhanced recovery in that pathway, essentially we're doing it, and it's become standard of care. And that's, of course, what we all wanted. It's what Henrik wanted back in the day. And it's nothing like the care that was delivered 20 years ago. That is enhanced recovery. And our focus now is perhaps a bit more on John's type work on prehabilitation and pre-optimization. For other major surgeries such as Whipple's, cystectomies, we're still very much wanting to have enhanced recovery pathway in place. It's more complex surgery, still longer length of stay. We still think we have some wins that we can have. So I think it is a bit of both, but I would love to. I'm not sure at some stage the term enhanced recovery is helpful. I mean, as I said, we've been using it for 20 years now. There's definitely a lot of fatigue with the term, it's all over the meeting. So I think we need to somehow reinvigorate enhanced recovery in those select higher risk patients, so where it's going to be most visible for sort of ERAS 2.0 or whatever we call it.
Okay, thanks very much. Let's move back to the research implementation side of things. Joyce, a slightly controversial suggestion here. Do UK consultants have too much autonomy that allows them to ignore latest evidence, rather than other European models where perhaps got a more hierarchical department lead approach, possibly academic clinical leads that set a strong direction and everyone has to toe the line?
It's a bit controversial. I think we're still in Europe. That's the first thing. I think UK consultants, all my colleagues, that includes me, have autonomy, and actually it's not a bad thing. We need that. We're a strong advocate for patient safety and well-being, and we're in charge of a patient in front of us. I do think we get swayed and influenced by our colleagues. And when we do trials and when we have 40, 50 sites, you talk to different sites, and every sites are different, doing something differently, each believing they're doing the best for their patients, which shows me that there's willingness to listen to each other. They're still willing to take part in research and willing to work together, find some new knowledge. So I don't think it necessarily is a barrier. I think autonomy is important because we still need to be confident in what we do. And as experienced clinician, you should judge each case based on the best evidence, best research out there. So I don't think it's a bad thing to be autonomous.
Question in the room, possibly following up from that?
Well, yes, I'm really interested what David thinks about that. And I'm actually sort of flipping things on Joyce a little. Do you think, so you're a trialist, equipoise, how helpful is that in terms of autonomy and judgment?
You will love it and hate it. I think there is enough equipoise in the anesthetic perioperative arena for important questions, but you really have to sell it to the clinicians, like, why is this important? Where do you think this will go? And there will be a proportion of clinicians, practitioners who will not shift from what they know what's best. And that's fine. I respect that. I think as long as there is enough equipoise left in the community to acknowledge there's still uncertainty and improvement, we can still move forward. But yes, it's a constant battle sometimes.
So can I come back on as also somebody who tries to run clinical trials? What was your experience been? Because when you were setting out to trial intravenous versus inhalational anesthesia, that immediately struck me as something that you might have quite a few battles on. And it was really fascinating to come to my centre. The response I got from colleagues was like, yeah, we feel balanced about these two things. We don't know, we'd love to, which was quite a surprise to me. I thought this would be something where there were existing strongly held beliefs. And then in other areas, it can be a real struggle to get people to allow that bit of their care to be subject to the randomization system. And I sometimes wonder if it's sort of going beyond equipoise and it's more about the load that people are able to take. If they're doing a busy case, if they're, doing X, Y, and Z, and actually if you're asking to do a new intervention or part of a trial that's actually quite difficult, that's distracting, that's not just this injection or that injection, actually things do get, the barriers come up more, and it's not necessarily about interpretive evidence, it's about workload, familiarity with working in trials, concerns about patient safety and so on. Do you think that is something you've seen. I mean, just talk to us about your experience of doing IV versus volatile, and you've recruited huge numbers of patients in a very short space of time.
Yeah, I was genuinely really happy and humbled that there were actually a lot of clinicians out there who are very interested in this question. But you're right, our practice could be different. It is, I think, although obviously I'm biased because I'm an anaesthetist, I think it's harder to do trials in a pressured area when you've got a list coming. There's already been delays, the bed is not available, surgery's been cancelled, there are lots of things competing for your attention. Compare that to someone, clinician, who may recruit people who come to a clinic, who comes in, you've got to sit down time, talk through everything, get them to sign consent form. I think it's a very different environment. I do think it will work. We will learn how to do these sort of trials better, try to work around some of the difficulties, but bed cancellation, changing anaesthetists, changing surgeons in the last minute, different dates, put pressure on patients, clinicians, and actually a research team to try to deliver the trial. But actually, in terms of equipoise interest, there's a lot of interest out there, which I think we were partially lucky. And I think when looking back, what was fortuitous is that I wrote it in a very conservative way. So I was expecting a lot of resistance. I expected recruitment to be very slow, because all the things that we've just discussed, but actually turn out to be, the volume of surgery that we see, the volume of people we get in contact with was higher. And so more research opportunities are there. And so it can still become a successful trial at the end.
David, a CEO's take on degree of autonomy for UK consultants. Do we have too much? Does it allow us to turn our backs on the evidence base and say, well, actually, I've got my way of doing it. I'm very special and I'm going to carry on doing it? Is that something you see? Is it a problem?
No. I think, it's really interesting, isn't it? Because as a CEO, you want to create a culture in an organization where there's a spirit of curiosity. So that culture means that people want to constantly get better, constantly try stuff, constantly feel that they can do that. So the first thing you try and do is always say to people, it's no problem failing. We've got to take risks. We are trying here to pitch ourselves as a genuine research hospital. And if we want to be a genuine research hospital, we need to have the structures in place that make some of the challenge that you've just been describing easier. We haven't managed to make it easier. It's still really, really difficult for people. In terms of the autonomy, it's really hard. We're very proud of the fact that, we have places here like Queen Square. So they're doing stuff at the National Hospital for Neurosciences that very few people, if anyone in the world, is doing. So there is autonomy built in already in some of the things that those people are doing. And I suppose what we always want to do is encourage that, develop it, make sure that people are safe, and develop a sort of peer group of people you can trust to make sure that autonomy never becomes dangerous, or that we always do what is right for patients and their well-being. The final thing I would say is that, again, I feel very lucky at UCLH. We are structured by clinical leadership. So I am the only non-clinician in the entire line of decision-making. We've deliberately gone about that because we want to make sure that it's very easy to go from board to ward on decisions and understanding how the organisation functions. But also in this end, even if there are autonomous mavericks doing autonomous and maverick type things, there is a whole clinical infrastructure above them to safeguard that. So at the moment, it feels relatively comfortable, but I am, again, in quite a lucky position where I am.
So I think in the room, James Holding was keen to perhaps ask a follow-up question or make a comment.
Maybe. I've got a couple of stories.
Come on, we got time.
I'm James Holding. I was clinical lead of the UCLH Department of Anaesthesia and Perioperative Medicine. I'm now clinical director. And my first story is when I was a new clinical lead, we were expanding and I was trying to get in consultants quickly. I interviewed a really good German anaesthetist who in the end we appointed. And I said to him, your CV, clinically it looks great, but normally I see consultants who've done, research and audit coming for this sort of job. He said, audit? What's audit? I said, when we go out and, for example, check we're adhering to the enhanced recovery pathway. He said, I come from Germany. If the boss says we do it like this, you don't need to audit it because everyone does it. So that's the first thing. As clinical lead, we started a robotic cystectomy pathway
And with that, we started with a particular prescribed anesthetic. This is the anesthetic you're going to give for this case. And that bristled the consultants because consultants like their autonomy. I do it this way. Yeah. And it wasn't that prescriptive. You could use a propofol infusion or you could use gas. It wasn't super prescriptive, but it did have some prescriptive elements. And it was a step for the group of clinicians to do, although it was very clear. But in fact, it's made it very reliable in that this is what a normal patient looks like in recovery after this operation. And it's really helped us push that through. So that's one in support of a defined anesthetic. I'm actually quite a fan of that, but you don't have to be too prescriptive. What I would say as a clinical lead, I think rather than define, I want everyone to have a propofol TCI anesthetic, because I'm not an expert in everything. And I also know that some techniques work better in some people's hands than other techniques. But what I am fanatical about is I want all the consultants to consider their outcomes. And I think maybe that's the job of your clinical lead, not telling you how to do it, but telling you need to be counting it, and then you need to be coming and presenting it with the other people who do this similar work. And let's make sure that your way of doing it is at least comparable to everyone else.
No, thanks. It's interesting.
We in the US now, we send all our data to EBPOM, the Michigan Perioperative Outcomes Group. So I get a monthly report on my outcomes. I don't know if you get any such reports, and it's things that you wouldn't necessarily know, like my AKI rate. And I will get my number, which will be, X out of 100, or however many patients I looked after, in my percent. And then I will get that compared to the average percent within the, similar group of anesthesiologists. So I get there's a variety of different numbers you can choose, but some outcomes like that, you get PONB, and you get compliance with measures like avoiding over transfusion, neuromuscular monitoring. But you can choose the outcomes you want, avoidance of hyperglycemia, etc. So it's the first time that we've ever had real-time, individualized feedback on what we do. And I think, again, in this era of electronic healthcare records, that's going to be the future. And as I say, you adhere to the pathway, but if you do things slightly differently and your outcomes are good, great. If you're an outlier, not so great.
Right, we've got about 4 or 5 minutes left before a coffee break, and it seems we are not going to be able to escape the robot behind us. It's the most highly voted question so far. Isn't robotic surgery a case in how we get it wrong? It sounds sexy and appeals to corporate ego, but it doesn't improve outcomes as much as cheaper, less glamorous stuff. There are more robots funded than prehabilitation services with a similar level of evidence, yet significantly differing costs. What's going wrong with implementation here? David, what do you think?
Well, I'll tell you something that when I was leaving I won't name it, a big academic hospital in London that had a big robotic program, there was a retiring stone surgeon who was a lovely man. And as a retirement speech, he was surrounded by all these robotic enthusiasts. And he said to me, surgical robots are fantastic. There are many things you can do with them, but he said the best is to melt them down and turn them into proper instruments. And he had this real strong view. So I'm aware there are different camps of opinion on all of this. And I'm not a clinician or a scientist, but I've done a couple of things throughout my career to try and understand it. First is to understand the science and the research that's being written about. And even through my eyes, some of that looked quite interesting and certainly did impact on things that I can measure, like length of stay. It just looked to me, again, with my eyes, as something that was positive. But most importantly, you listen to your constituents, and our surgeons are big supporters of it. It's growing. Very expensive, but patents have come off machines and the market is opening. So plenty of opportunity, I think.
Any other thoughts on robots from the panel?
Well, I obviously live in the US, so we use robots a lot. My general impression is it's very dependent on the surgery. I think robotic prostatectomy has made a difference in outcomes, and I think I don't know the evidence base well, but I think there is evidence. We're starting to do robotic hernias, robotic and gynecologic surgery has been going for a while. Less confident that either of those have made a significant difference in outcomes. the bigger surgery that we're now doing, colectomies, seem to have a quicker learning curve for the surgeon, and he's speaking to the surgeons rather than laparoscopic, and that may well be a driver. We're starting to do robotic, living donor hepatectomies, which I think is a huge improvement for the donor. So I think it's dependent on the type of surgery, but it's growing and growing.
Okay, fine. Well, I think with that, we're just coming to 10:30, so we'll round up our first session. It's been a great first session, some fantastic discussion and presentations. We've got a half-hour coffee break. We'll be back here for our next session after that, so do join us, and please just join me in thanking our fantastic speakers and panel.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.